Welcome students to this lecture session on chemotherapy of human immunodeficiency virus infection part 1. The specific learning objectives of this session is to describe the purpose of treating HIV infection, explain the entry of the virus into the host cell and its replication, describe the targets of antiretroviral drugs, classify antiretroviral drugs with examples, describe the mechanism of action and the adverse effects. Every year, the 1st of December is commemorated as World AIDS Day. The purpose is to make the people aware of HIV/AIDS as to the prevention and treatment of this condition. This is the structure of the human immunodeficiency virus, which is called as a retrovirus. Some important components I will tell you. One is GP120. This helps in anchoring the virus to the surface of the host cell. GP41. This helps in the fusion of the viral envelope with the cell membrane of the host. You can also find two enzymes here. One is called as the integrase enzyme. This helps in integrating the viral DNA into the host chromosome. You can also find another enzyme called reverse transcriptase enzyme, which helps in the formation of DNA from viral RNA. And one more enzyme is also important, that is called as protease enzyme, which helps in maturation of the daughter virions. Now, what is the purpose of chemotherapy? First of all, it is a single-stranded RNA virus. The drugs used here are called as antiretroviral drugs. Normally, it is the DNA which is transcripted from, it is RNA which is transcripted from DNA. But here it is the reverse. It is DNA which is formed from RNA. So it is called reverse transcription. That is why human immunodeficiency virus is called as retrovirus. So the basic purpose of treating HIV infections is to prolong and improve the quality of life. A permanent cure is not possible because the viral DNA integrates into the host genetic machinery. So the objective is to maximally suppress viral replication for the maximum period of time. And how can we assess the response to treatment? One, by the viral RNA count and the helper T lymphocyte count. So the treatment should reduce the viral copies and increase T lymphocytes. Antiretroviral treatment postpones the complications of acquired immunodeficiency syndrome and AIDS-related complex. Now, the prevalence of infection and mortality rate because of HIV has reduced considerably throughout the world because of antiretroviral treatment. This is because the HIV load in the patient, the count is reduced, because of which the immune system is protected. Hence, the advantages are obvious. Zidovudin was the first antiretroviral drug to be introduced in 1987. This virus primarily affects the T helper lymphocytes. That is why cell-mediated immunity is suppressed, because of which the person becomes more prone to get infected. Later, macrophages and other cells are also affected. So when the T lymphocyte count goes to less than 200 cells per microliter, the cell-mediated immunity is reduced and the patient becomes susceptible to many infections, because of which he may lose his life also. Antiretroviral drugs are predominantly used in combination of a minimum of 3 drugs for maximal efficacy. And also, please remember, the purpose of combining these drugs is to prevent the emergence of resistance. So this form of treatment, where we combine 3 drugs, is known as highly active antiretroviral therapy, HART regimens it is called. Now, what are the targets of antiretroviral drugs? So this particular picture which I am going to show you will clearly help you to understand what are the targets. So in this diagram, you find the HIV organism. First of all, it anchors onto the surface of the host cell, the CD4 host cell. So you find there CCR5, that is a receptor on the surface of the T lymphocyte, which provides anchorage for the virus. Once the virus anchors itself, the viral envelope, it fuses with the plasma membrane of the host cell. This helps in the entry of the viral RNA into the host cell. So once the RNA enters into the cytoplasm of the host cell, because of reverse transcription, the RNA is converted into proviral DNA. The proviral DNA, it translocates into the nucleus along with an enzyme called integrase. This integrase enzyme, it cuts the host chromosome and helps the proviral DNA to enter or integrate into the host chromosome. Now, the proviral DNA utilizes the genetic machinery of the host cell and helps in transcription of the viral genomic RNA and mRNA. And this mRNA helps in the translation of various proteins. These proteins are assembled and they are released later on. Because of protease enzyme, they undergo maturation into fresh virions, which are able to infect further cells. So all these steps which I told you, right from the anchorage to the fusion, the reverse transcription, integration, later on maturation, they are the targets for antiretroviral drugs. So we have entry inhibitors, fusion inhibitors, reverse transcriptase inhibitors, integrase inhibitors, protease inhibitors. So as you can find the list of the targets for antiretroviral action. So CCR5 receptors, chemokine co-receptor, which provides anchorage, the fusion, which is responsible for entry of the virus into the cell, reverse transcriptase, which is responsible for converting RNA into DNA, integrase enzyme, which helps in integrating the proviral DNA into the host DNA, protease enzyme, which is responsible for maturation of the virions. So this is the classification of antiretroviral drugs. We have nucleoside and non-nucleoside reverse transcriptase inhibitors. NRTIs, zidovudin, lamivudin, stavudin, diadenosine, abacavir, tenofovir, emtricitabine. Nevirapine, efavirenz, etravirin, delavirdin, rilpivirine are non-nucleoside reverse transcriptase inhibitors. Protease inhibitors are indinavir, saquinavir, lopinavir, atazanavir, ritonavir, nelfinavir. Maraviroc is a chemokine co-receptor 5 receptor inhibitor. Enfuvirtide is a fusion inhibitor. Raltegravir, dolutegravir, elvitegravir are integrase inhibitors. Now, the nucleoside reverse transcriptase inhibitors are basically nucleoside analogs. For example, zidovudin and stavudin are thymidine analogs. Diadenosine is a purine nucleoside. So they resemble the nucleosides. An exception is tenofovir, which is a nucleotide analog. So these drugs have to be activated by phosphorylation. Only then they can interfere with the reverse transcriptase enzyme. So this results in interference with the formation of proviral DNA. Hence, there is no multiplication or replication of the human immunodeficiency virus. These drugs can also get incorporated into the proviral DNA which is already formed, and they will interfere with the elongation of this proviral DNA. Now, some of the important adverse effects, they all can cause gastrointestinal adverse effects because they're all given orally. The most important adverse effects are dose-dependent anemia and neutropenia with zidovudin, that is bone marrow depression. Diadenosine can cause very severe adverse effects, acute pancreatitis, peripheral neuropathy, which is stocking and glove type. That is why diadenosine is not preferred. Stavudin can cause metabolic complications like lactic acidosis and also peripheral neuropathy. That is why even stavudin is not preferred. Abacavir can sometimes cause hypersensitivity reactions, which can be very serious. This is because of excessive release of tumor necrosis factor alpha. Patients with a history of hypersensitivity reactions to abacavir should not be given this drug. Whereas lamivudin, tenofovir, emtricitabine are very well tolerated. Hence, they are the nucleoside reverse transcriptase inhibitors which are more commonly used. So NRTIs are included in the first line antiretroviral regimens. As I told you, we use a minimum of 3 drugs, a combination of 3 drugs. One reason is enhanced efficacy and synergism. The second reason is to prevent the emergence of resistance. So in the first line antiretroviral heart regimens, NRTIs are always included, and please remember they are used in combination with at least other 2 antiretroviral drugs. Why can't I use these drugs alone? Because there is emergence of resistance because of point mutations in reverse transcriptase. Suppose I use a drug alone. For example, I use zidovudin alone. In 1 to 2 years, 50% of the recipients, they show resistance and they will not respond to zidovudin. That is why combinations of drugs are used. A minimum of 3 drugs are used to prevent resistance. Zidovudin and lamivudin tablets. Let me add one point. Lamivudin also has efficacy against hepatitis B virus. It also interferes with hepatitis B virus DNA polymerase. Tenofovir emtricitabine. They are more commonly used nucleoside reverse transcriptase inhibitors because they are very well tolerated. Like lamivudine, these two drugs are also having efficacy against hepatitis B virus. Abacavir is used, but please take care. If the patient is having history of hypersensitivity to abacavir, don't use it again. Now coming to the other class of reverse transcriptase inhibitors, these are non-nucleoside inhibitors. They are not structurally similar to any nucleoside. They don't need activation for their action. These are nevirapine, efavirenz, etravirin, delavirdin, rilpivirine. Of course, these drugs are also used in combinations with NNRTIs and protease inhibitors. As we've already discussed, a minimum of 3 drugs are used in combinations. Nevirapine is hepatotoxic. So patients with hepatic insufficiency or hepatic damage, we prefer to use efavirenz. Both these drugs, efavirenz and nevirapine, exhibit cross resistance. If there is resistance towards nevirapine, don't substitute it with efavirenz. But you can use etravirin because etravirin doesn't have any cross resistance with these two drugs. And NNRTIs are also used in first line antiretroviral regimens. Nevirapine and efavirenz tablets, both these drugs are non-nucleoside reverse transcriptase inhibitors. They don't need to be activated for their action. Etravirin is used whenever there is resistance to either efavirenz or nevirapine. Coming to the third class of antiretroviral drugs, protease inhibitors. So protease is an enzyme which acts at a later step in viral replication. That is, after the formation of the polyprotein, that is after the translation happens, when there is integration of the proviral DNA into the host DNA. So this polyprotein is broken down into separate proteins which once again undergo assembly, which is followed by maturation. So this maturation is inhibited by protease inhibitors like indinavir, saquinavir, lopinavir, atazanavir, ritonavir, nelfinavir. And there is one more drug called fosamarinavir. So whenever we use protease inhibitors, immature virions are formed. These immature virions are not able to infect fresh cells. They are indicated in second line regimens. The previous two classes, they are indicated in first line antiretroviral regimens, but protease inhibitors are indicated only when the first line regimens fail. These drugs are not included in first line regimens because they have a high tablet load. The patient may have to be administered 6 to 18 tablets every day. Metabolic complications are also seen like lipodystrophy and various other complications. And these drugs are always used in combination with low dose ritonavir, that is 100 milligrams of ritonavir, which improves the bioavailability of the concurrently given protease inhibitors. For example, lopinavir is always used along with low dose ritonavir because in the presence of ritonavir, the bioavailability of lopinavir is increased and also the systemic metabolism is reduced. The implication is there is reduced tablet load. Except nelfinavir, all the other protease inhibitors are used along with low dose ritonavir. So this is fosamarinavir, and you find the combination of lopinavir and ritonavir. In fact, lopinavir is always available in combination with ritonavir. Indinavir and saquinavir. Indinavir can cause nephrolithiasis. Hence, we should advise the patients to drink a lot of water. Nelfinavir. This is the only protease inhibitor whose bioavailability is not increased by ritonavir. Coming to the fourth class, CCR5, chemokine co-receptor 5 receptor inhibitor maraviroc. This drug antagonizes CCR5 receptor by binding to GP120. That is, GP120 is the one which helps in binding of the virus to CCR5. So maraviroc binds to CCR5 and prevents the anchoring of the virus by GP120. So what happens is, if the virus cannot anchor onto the surface of the host cell, it cannot enter into the cell itself. So the integration, the reverse transcription, the replication of the virions cannot take place at all. What is the role of maraviroc in the treatment of HIV? It is used as an addition to the already existing background optimized regimens. So as I told you, three drugs are used in combination, that is NNRTIs, NRTIs, and protease inhibitors. So if these three drugs are not giving the required response, that is the decrease in HIV count, increase in T lymphocyte count, then we can add maraviroc to improve the response. Maraviroc tablets, which are CC5 inhibitors, they prevent the anchoring of the virus onto the host cell. Coming to the fifth class of drugs, fusion inhibitor, enfuvirtide. Now we saw there is a glycoprotein 41 in the HIV structure. This GP41 is responsible for fusion of the viral envelope with the host cell membrane. Enfuvirtide binds to GP41 and prevents the fusion. So the viral RNA cannot enter into the host cell. So the further steps in the replication will not take place. Enfuvirtide is injectable in nature. Till now we saw all antiretroviral drugs are given orally. So because it is injectable, it becomes a disadvantage, and there are some adverse effects like pain at the site of injection, formation of nodules, cysts at the site of injection. Enfuvirtide, like maraviroc, is added to optimized regimens to improve the response. Enfuvirtide injection, which is added to optimized triple drug regimens to improve the response. Coming to the last class, that is the sixth class of antiretroviral drugs, the integrase inhibitors. So as we have already studied, integrase is an enzyme which is already present in the virus. This integrase, it enters into the nucleus of the host cell along with the proviral DNA. Once in the nucleus, the integrase enzyme, it cuts the host DNA and allows the proviral DNA to get integrated into the host genetic machinery. So raltegravir, dolutegravir, elvitegravir, they interfere with integrase enzyme and prevent the integration of the viral DNA into the host DNA. So this will prevent the formation of fresh HIV RNA copies. That is how integrase inhibitors act. These drugs are very well tolerated. So raltegravir, dolutegravir have been used in the first line regimens along with RTIs, that is NNRTIs, NRTIs, but they are very expensive. So that is about the integrase inhibitors. Dolutegravir, raltegravir tablets, which are integrase inhibitors. They are expensive, but because they are very well tolerated, very efficacious, they have been included in the first line antiretroviral regimens. So we have come to the end of this lecture on chemotherapy of HIV infections, part 1. So now we are in a position to describe the purpose of treating HIV infection, explain the entry of HIV into host cell and its replication, describe the targets of antiretroviral drugs, classify antiretroviral drugs with examples, describe mechanism of action of antiretroviral drugs, and describe the adverse effects of antiretroviral drugs. So thank you very much and happy reading.